so far. And not only that, with this being the first video of 2025, I hope you're having a great year so far. Hope everyone had a great New Year's Eve, and as we start the new year off, let's start it off on the right foot. And we're going to continue on with our anatomy series here. And where we left off last time was the muscle facts. We finished in part 3. And now we're going in to something a little bit different. We're going into the arteries and the veins of the back. So we're going from musculature to really some of the hard-hitting support features of your body. I mean, you don't have oxygenated blood, you don't have life. So let's get into it. Figure 4.1, the arteries of the back. It says the structures of the back are supplied by the branches of the posterior intercostal arteries, which arise from the thoracic aorta or from the subclavian artery. So, right in here we've got the abdominal aorta, which is one of the largest vascular structures in the body, if not the largest. And then the thoracic aorta coming up off of that, the subclavian arteries up here, the common carotid artery is up here, and then the brachiocephalic trunk and the aortic arch. The aortic arch is what's coming immediately up out of the heart, so that's the primary feed from the heart. But here are the posterior and the anterior intercostal arteries, so that's going to provide blood or oxygen to your intercostal muscles around the ribs. And let's see here. We're going from the back here up into the neck. The internal carotid artery and the external carotid artery, and then the common carotid artery. Common being it's the main thoroughfare, and then it splits or bifurcates off here into different branches. And then the vertebral artery, aptly named because it's protected by these vertebral transverse processes there. And then we've got the thyrocervical trunk coming off, and then the subclavian artery, the internal thoracic artery, the costocervical trunk, the first posterior intercostal artery, and the second posterior intercostal artery. Let's see. Yeah, so we've got a right lateral view here. I don't want to just assume that everybody knows here. And then over here for figure B, it says the vascular supply to the nuchal region, posterior lateral view. Note the first and second posterior intercostal arteries arise from the costocervical trunk, a branch of the subclavian artery, which we can kind of see that. The subclavian, and then they're coming off of that. 1 and 2. And then in figure C, we've got posterior intercostal arteries, oblique, posterior superior view. The posterior intercostal arteries give rise to the cutaneous and muscular branches, as well as the spinal branches that supply the spinal cord. So it says posterior, or oblique posterior superior view. So here is the spine right here. So here's the person's back. We're slightly up a little bit, and we're looking down into this picture here. So this is going to be where the sternum would be here, and I mean the sternal branches. So we know I'm right. Thumbs up. And then the anterior cutaneous branch is here, and the sternal branches are coming off of that anterior cutaneous branch. And then we've got lateral cutaneous branches coming off and going around, and then medial cutaneous branches going to the middle. The dorsal branch, or the back branch of the posterior intercostal artery. And all of this is feeding off of the thoracic aorta. So again, hugely important structure here, running just anterior to your spine. And then vascular supply to the sacrum, the anterior view. Again, the abdominal aorta. So we're just looking here at the see because you saw it up here. Common carotid, and then internal and external. So main thoroughfare, and then a branch. Main thoroughfare, common iliac, and you've got the internal and the external, and then some branches coming off even of that. And again, everything coming out of the abdominal aorta. Now, for every artery that you have taking taking oxygenated blood to the structure, you have veins that are going to be returning deoxygenated blood, or blood that has dropped off their oxygen. You're going to be bringing it back to the heart to be reoxygenated by the lungs. So anytime you see an artery, you're more likely than not going to see a vein paired with it. So veins at the back. The veins at the back drain into the azygous vein via the posterior intercostal veins, the hemiazygous vein, and the ascending lumbar veins. The interior of the spinal column is drained by the vertebral venous plexus that runs the length of the spine. So let's try and find that vertebral venous plexus first. It's not immediately evident on this figure A. So let's go ahead and go deal with what we've got here. Inferior vena cava, that's going to be the large vascular counterpart to the thoracic aorta, inferior vena cava. And then you've got subcostal veins that are coming back here. You've got the external iliac vein coming up into here. So think for arteries to carry blood. The rule of thumb, or an easy way to remember, is arteries A, and then away from the heart. Veins are returning everything back to the heart. So posterior intercostal veins pair with the posterior intercostal arteries. Anterior intercostal veins pair with the arteries. And then we got the right subclavian vein, the right internal jugular vein. And if you ever see anybody like really strain or anything like that, and you see a vein pop out in their neck, it's most likely the jugular vein. Superior vena cava is here, so the inferior portion is low and the superior portion is high, returning that blood back into the heart. And then it's giving us a cool view here at vertebral venous plexus, posterior view. So we're looking at the back of the person with the vertebral canal windowed in the lumbar and sacral spine. The external vertebral venous plexus communicates with the sigmoid sinus through emissary veins in the skull. The external vertebral venous plexus is divided into an anterior and posterior portion that run along the exterior of the vertebral column. The anterior and posterior internal vertebral venous plexus run in the vertebral foramen and drain the spinal cord. So we've got a superior sagittal sinus, transverse sinus, which makes sense, cuts across here, sigmoid sinus, the emissary veins, external vertebral venous plexus, internal jugular vein, just a different look at that there. The right brachiocephalic vein, the left brachiocephalic vein, the superior vena cava, accessory hemiazygous veins, the azygous vein, which feeds the accessory, feeds into the esophagus, and then the posterior intercostal veins and the hemiazygous vein also coming into the azygous. And then the external vertebral plexus running through all these vertebrae, posterior internal vertebral venous plexus, lumbar veins, ascending lumbar vein being fed by the lumbar veins, external iliac vein and internal iliac vein, and then anterior internal vertebral venous plexus is all running through here, and that's what's taking care of the spinal cord. Alright, this is a tricky looking picture here, so let's go ahead and orient ourselves. It says intercostal veins and anterior vertebral venous plexus, anterior superior view. So where it was here was the posterior superior view. We have turned our orientation this will not always be the case, this is structure, but there is kind of a rule of thumb more often than not that they call it the Van rule. So Van, V, A, N, V being vein, A being artery, and N being nerve. They don't always run exactly that way. I mean, it can partially be depending on your orientation, where you're looking, but they almost always run in conjunction with one another. So the back receives its innervation from the branches of the spinal nerves. The posterior dorsal rami of the spinal nerves supply most of the intrinsic muscles of the back. The extrinsic muscles of the back are supplied by the anterior or ventral rami of the spinal nerves. So, what are we looking at here? This is a cross-section of the vertebral column and spinal cord with surrounding musculature superior view. So we're looking down in, and I'm guessing, or based on the size of this vertebral body here, that we're probably at least in the T-spine, if not in the L-spine. Yeah, probably the T-spine, because we have the presence of the esophagus here. And then here's the aorta. Here is the the sympathetic paravertebral ganglion. The white and gray rami communicates. The meningeal branch here. The medial cutaneous branch here. The lateral cutaneous branch here. And then we've got the outer layer of the dura mater, the inner layer, the arachnoid mater, and then the anterior root is, let's find that, tucked right in here. We've got a spinal ganglion right here, this big structure. Posterior root is running right here. So anterior root and posterior root. And then the spinal nerve is coming off of here. And then the anterior or ventral ramus is here. And the posterior or dorsal ramus is here. So a few different structures identifiable, and that will be kind of thematic going forward, is the idea of a ramus, which is kind of a thick portion of an offshoot of the ganglion. So we've got an anterior and a posterior version of that. The ganglion itself is something we can look for. The actual spinal nerves it runs along. These are the portions that sometimes experience compression in instances like sciatica and things like that. But not relevant to this specific cross-section here, but just something that you hear a lot about, and a lot of times it's coming through this kind of little foray right here where the experience is the compression, which gives the symptomology that we'll probably end up talking about later. Figure 4.4, nerves of the nuchal region. We're looking at the right side posterior view, pretty obvious. I mean, you can see the ear here helps. Like the back, the nuchal region receives most of its motor and sensory innervation. I'm going to call a quick timeout here. Every nerve carries motor and sensory function. So motor being functional, it allows you to move, and then sensory is what allows you to feel. So the nuchal region receives most of its motor and sensory innervation from the posterior rami of the spinal nerves. The posterior rami of C1 through C3 have specific names. The suboccipital nerve, C1. The greater occipital nerve, C2. And the third occipital nerve, C3. The lesser occipital and great auricular nerves arise from the anterior rami of the C1 through C4 spinal nerves, or cervical plexus. I told you that would come up again. Or no, that's more the brachial plexus, but there is a cervical plexus. And innervate the skin of the anterior lateral head and neck. The anterior rami of C1 through C4 also give rise to the ansa cervicalis, which innervates the infrahyoid muscles. And that's seen on page 620. So again, we're on page 38. You're going to have to hang out with me for a while to get to that point. But we also see here, we have the supraclavicular nerve coming down here. That's one of the ones we didn't talk about there. And then of course, the lesser occipital nerve. Cutaneous innervation of the back. Color denotes the skin areas innervated by A, particular peripheral nerves, or B, particular pairs of segmental spinal nerves. Patterns of loss of cutaneous sensation can be helpful in diagnosis of nerve lesions. various innervation patterns of the specific peripheral nerves. We've got the greater occipital nerve here, the lesser occipital nerve here, the great auricular nerve here, the supraclavicular nerve here, which you can see right here, runs down and takes care of this whole portion right here. We've got medial cutaneous branches all through here, an axillary nerve here, intercostal nerves, anterior rami, lateral cutaneous branches. Please forgive any background noise here. It sounds like the trash is being picked up for the day, so they're not operating on a on a schedule that's considering anything being recorded. It is what it is. Please forgive the noise. Should be passing here shortly. And then we've got the iliohypogastric nerve down here, the superior cluneal nerve here, the medial cluneal nerve here, and then the medial cutaneous branches and the lateral cutaneous branches come together to be a part of the posterior rami of the spinal nerves. Now, dermatomes. Dermatomes are also an interesting thing because dermatomes, I don't know if you've ever heard of the shingles before, but the shingles is basically adult chickenpox. It's way worse than childhood chickenpox. That's part of why back in the day they used to make sure that kids got chickenpox so that they wouldn't have to deal with shingles as an adult, or it's much less likely that they would have to deal with shingles as an adult. These dermatomes the shingles can show up on the specific dermatomes that usually follow a dermatome pattern. So, dermatomes are bilateral band-like areas of skin receiving innervation from a single pair of spinal nerves from a single segment of the spinal cord. Note, spinal nerve C1 is purely motor. Consequently, there is no C1 dermatome. Now, the reason that shingles runs along these dermatomes, or these areas of innervation, is because the chickenpox virus literally will crawl up the nerve. And so that's where you see any discoloration or disease. That's where it's followed the nerve all the way through. If you don't believe me, look at it for yourself. Look up shingles rashes, and you'll see that they typically follow a specific band. But we've got C2, C3, C4, which is interesting because it's down further. C5, C6 is all the way down here. C8 here, T1, and then this is also T1 all the way down here. And then L1, so, T1, 2, 3, 4, 5. It's following the specific thoracic innervation, the nerve root there. Now, the spinal cord. This is a good one. This one could be a video unto itself, and it very well might be at this point. I'll do a quick overview of the spinal cord, and then we'll pick it up more in depth next time. The spinal cord, the dura mater of the cranial cavity, is composed of two layers, the periosteal and the meningeal. Only the meningeal layer extends into the vertebral canal with the spinal cord. The periosteal layer of dura terminates at the foramen magnum and is replaced in the vertebral canal with the periosteum of the vertebral bone. Due to the structural difference in the two regions, the dural sac is not adherent to the bone of the vertebral canal as it is in the cranial cavity. So, spinal cord in C2. Posterior view with the vertebral canal windowed. So, we've got all the vertebral bodies taken off the back, and we can see the medulla oblongata here. Well, that's always a fun word for a lot of people to say. The C1 spinal nerve is shooting off here, and then there's the atlas or C1, so they're right in direct relationship with each other. Vertebral prominence down here is C7, cervical enlargement, T1 spinal nerve, T12 vertebra, and lumbosacral enlargement down here. L1, conus medullaris, which we'll get into that, where we already did talk about that a little bit, where the spinal, or the nerves start to shoot out, and then they truly separate down here at the cauda equina, or the horse's tail, as we talked about before. sacral hiatus. I think this is a good place to stop. We'll go ahead and get into the spinal cord and its specific layers next time. And yeah, we'll do all things spinal cord because again, I think that's a video that's worth standing on its own. Oh, and we can also get into the arteries and the veins, so we can see how the vasculature is takes care of the blood supply for the spinal cord. So, with that, welcome to 2025. Hope your year's off to a great start so far, and looking forward to what this year will carry and bring. So, thank you for spending time with me. As always, if you like what you see, please like and subscribe if you'd like to see more. And if you have any feedback, anything you'd like to see more of, anything you'd like to see different